يديك العافية يا رب. الحمد لله.
معكم دكتور Abdullah. I'm a cardiac surgery consultant في البطين. I was asked by the organizing committee to talk about preoperative CABG off pump. And regarding the guidelines, I'll go through quickly the latest ACC guidelines. And then I prepared 3 short cases, and we can go through them as a mock oral. And I'm hoping that we could finish all of this like back to back. Inshallah على صلاة الظهر at max. We'll see how it goes يعني. I'm hoping to finish before 1 o'clock because I have an appointment. Right, let's start. Okay, Bismillah ar-Rahman ar-Rahim. The incidence of reoperation for coronary artery bypass graft. So if you look at this table, it shows the freedom from re-intervention at 12 years around 99%, at 5 years around 97%, and at 10 years around 89%, and around 15 years around 72%. And I believe the freedom of reoperation is even higher nowadays. Do you guys know why?
Because of the intervention.
That's a reason. What else? Common.
Medical therapy.
What is that?
Medical therapy.
Yes. So better medical therapy. What is the main drug that helps keep your graft open longer? Can you guys tell me?
Antiplatelet.
And?
Aspirin, and actually the study showed the statin.
Statin. So statins are very important. So when you do a bypass to your patient, make sure he's on statin. And what else?
Medication-wise, okay, for graft occlusion medical therapy, which is aspirin and clopidogrel if it is off pump, as well as the statin. Then also the beta blocker controlling the glycemic index is very important. Also being shown in multiple studies to affect the longevity of the graft.
And surgically, what is the difference nowadays?
The graft is responsible for the longevity.
That's true. If you guys believe it or not, up to the early 1990s, Lima was not the gold standard. A lot of the CABGs in the 80s and early 90s was mainly veins. So Lima was started to pick up at the early 90s. It became the standard of care by the end of the 1990s. And then, you know, nowadays you have to use the Lima. Okay, let's go on. So predictor of reoperation is preoperative angina, choice of conduit as a primary CABG if you use only vein, previous MI, a female gender, smoking, and young age. So causes for need of reoperation is either incomplete revascularization, progression of your native vessel disease, and graft failure. So this chart shows the causes of vein graft failure at different time intervals. Acute is defined less than 30 days, and it mainly happens due to technical failure. Can you guys tell me what technical failures that could happen?
Over distension of the vein.
What does it cause? What does it cause over distension of the vein?
Intimal disruption and accelerate the injury on the vein graft. Any tight, I mean, how I call it, technical issue like making the anastomosis too tight or taking part of the posterior wall.
What do you mean too tight?
He means tension on the graft.
Tension on the graft? Or what do you mean purse-stinging your distal anastomosis? Is that what you mean?
Yes, thank you.
So how do you avoid that? How do you avoid a purse string effect?
You don't take the stitch on the deep on in the posterior wall or the lateral wall. You take it on the edge of the coronary.
Yeah, and
now, when you tie, you distend the vein while you're tying, or you open the Lima.
You could do that, but takes the distance between your bites should be smaller. Let's say if you do your distal anastomosis, I think minimal 12 bites for your distal anastomosis. If you do less, you may risk restricting your anastomosis. And as some of you guys mentioned, you should not take the back wall. So be careful when you do your bite. Make sure you take the lateral wall or even the anterior wall or the upper wall of the coronary. Okay,
you don't take deep. Sorry, you don't take deep stitch on the heel or toe and in the angles,
and even the sides.
Yes.
So what if you took deeper bite on the side? You will have what they sometimes call a seagull effect. What's a seagull effect? السيجل هو الطائر هذه في البحر. So you found that your heel and toe is bulging, but midway is flat. هذا affect the flow, يعطيك turbulence of flow ويسبب thrombosis and occlusion. فmake sure your bite is always at the edge and close to each other. And not less than 12 bites generally to finish your distal anastomosis. So conduit related factor, either small caliber vein or pre-existing vein pathology, like what? Do you guys know?
What again?
So we're still at the acute stage. So conduit related factor, either a small diameter, which is obvious. The other one is pre-existing vein pathology, like what? Commonly we see.
Varicosities.
Exactly. And less rarely, sometimes some patients will have some fibrosis in the vein, don't ever use that vein. So generally what I always say, if you don't have a good vein segment, good caliber uniform, try to avoid it. And intrinsic factor is either thrombosis, limited flow, and hypercoagulable state. Between early vein graft failures between 1 to 24 months is secondary to new intimal hyperplasia and thrombosis, and late vein graft failure is related to atherosclerotic degeneration and generalized new intimal hyperplasia. So if you compare reoperation versus PTAs, factor that favor reoperation is late stenosis more than equal or more than 5 years, multiple stenotic veins, diffuse atherosclerotic vein graft, stenotic LED vein graft, very important, no patent ITA graft, and abnormal LV function. Factors that favor PTCA is either early stenosis less than 5 years, single stenotic vein graft, other patent vein graft, focal graft lesion, patent ITA to the LED, and a normal LV function. So this is the only sentence I could find the ACC guideline regarding reoperation. So in patient with patent lima to LED artery and ischemia in the distribution of the right or left circumflex coronary artery, it is reasonable to recommend reoperative CABG to treat angina if guideline directed medical therapy has failed and coronary stenosis are not amenable to PCI. If you look at the European guideline, IMA is a conduct of choice for radio CABG in patient whom the IMA was not used previously. Radio CABG should be considered for patient without a patent IMA graft to the LED. So revascularization conduits. So you have a previous vein conduit. What do you do with it? Either leave it alone if it's patent. You can divide it and replace it with another vein or arterial graft. If a lima was not used, if the LED was bypassed with an old vein graft, then don't occlude the vein graft. It will cause what they call a hyperperfusion syndrome. So when faced with replacing a stenotic or patent vein graft during reoperation, you have these options. You could occlude the old, divide the old vein graft and replace it with a new one. You could just place an LED distal to the old vein graft. You could divide the old vein graft, place a lima distal to the old vein graft, and place a vein to the diagonal. And lastly, you could divide the old vein graft and place the lima to the LED. So from you guys, who do you think will do worse of these patients? For them. Do you guys know?
Putting lima and occlude the vein graft.
Why is that?
Because lima, it takes time to be efficient like the previous vein graft.
Exactly. And cause what we call, I mentioned it in the previous slide. It causes a syndrome.
Hyperperfusion syndrome.
Exactly. Exactly. Do you think it will cause a competitive flow with time?
No, because the vein graft, it's patent but stenotic.
Exactly. Exactly. So least likely it will cause competitive flow and occlude your lima. So I think we all mentioned that. So I don't have to go through this slide much. Okay. So anastomosis, what option of anastomosis you have? Either you could do a sequential. A sequential, it's 2 consecutive distal done on a single conduit. And these 2 distal are in the same territory. You could via graft or TIA graft. You could use another in situ arterial graft, for example, AREMA. You could use the distal size of the previous vein graft for your distal anastomosis. What you could remove you can cut the distal anastomosis and leave a rim of vein. You could use that to apply your new distal anastomosis. And you can use the hood of the vein graft proximally to use your proximal anastomosis in the aorta. Is that clear? Do you guys have any questions? Yeah.
No, thank you.
Okay, CABG versus PTCA. As we all know, you always you can get complete revascularization with CABG versus PTCA, but with higher in-hospital complication with CABG, and the group in Cleveland showed no benefit in survival at 3 years. So preoperative concentration. So you got the patient in your clinic or as an inpatient consult, and they ask you to do a redo CABG. So important thing that you should know before making your final decision: 1, you should have enough detail about the old coronary anatomy, what was the first surgery, and it's possibly better to have the operative report. And you have to see the latest angiogram. At past medical history, you should take your regular past medical history, physical examination, but what is important specifically if the patient had history of mediastinitis, especially if he required deep wound debridement and requiring PEC flaps. At that time, you would really consider doing a reduced sternotomy on this guy, because the chances of recurrence of mediastinitis is extremely high and healing is extremely low. Meds that you should take care of when you see the patient, if the patient is anticoagulation, antiplatelets, and devise enough time to stop them before you redo sternotomy. Do an X-ray. X-rays are simple, but can give you a lot of information. You need a good PA and lateral X-ray. You can look at the wires, the way the wires were placed, the number of the wires, and you can see here on the lateral view, you guys see this? If you see the blackish area indicating that the RV is reasonably far away from the posterior table, and sometimes you can even see how close is your ascending aorta. Yeah, guys, any questions? Go ahead.
Thank you, very clear.
CT chest, it was mentioned in the previous lecture. CT is extremely important. You know the size and position of your cardiac chambers, path of your bypass conduit. CT angio is very important to know the patency of your graft and anatomy of the bypasses and related structures. So this is a short 3D reconstruction. You guys can see here that the lima is way lateral to the midline, and you can see there is a patent lima that you might use in your redo CABG. So this is a cranioangiogram. Do you guys tell me what you can see?
Patent, can you run it again, please? Patent lima to LAD.
Okay.
And there is giving collateral to the right.
Mm-hmm.
And yeah, and there is the proximal part is close to the midline, but the rest of it, it's away from the
Yes.
midline.
So what does it tell you at that part? What was there? It tells you that that spot, it might have the vein graft previously that is 100% occluded.
Mm-hmm.
Okay. So myocardial viability is extremely important if you decided to go for redo CABG to assess the reversibility of your LV dysfunction, a viable or non-viable myocardium, the modality as was mentioned in the previous lecture. So DPTM echo mainly look at the contractile reserve, PET scan looked at the metabolic activity, thallium scintigraphy looked at the myocardial perfusion, and MRI looks mainly at the contractile reserve. So before deciding to go ahead with the redo CABG, you have to make sure that the area you're gonna bypass is viable.
Doctor, the cardiologist prefer PET scan, but as a surgeon, which best modality for us?
It depends on the center you work with. The more, the better. To me, thallium is the worst. Me personally, I prefer MRI and DPTM echo to look at if there is any contractile reserve, and you could use PET scan. So the best is if you have two modality. One looks at, like for example, if you have PET scan and DPTM or PET scan MRI, I think that's good. Mm-hmm. At least two modality if you decided to go ahead.
Thank you.
Okay, so you decided to do CABG, you have to make sure you have conduits. So you could do venous mapping to look at the lower limb, to look at other segments of greater saphenous vein. You could even assess the lesser saphenous vein if it's a good caliper, you want to use it. You could do arterial Doppler at the radials and see if they're good enough to be used. And you can also assess the REMA if it was not used previously by Doppler or angio, if it's patent. Okay, we'll talk about approach to surgery. Okay, so question for you guys. What common structure you might injured going through a redo sternotomy?
RA and RV.
And with redo CABG, commonly?
And conduit.
Conduit, extremely important. So common structure are the right ventricle, right atrium, innominate vein, lungs, and venous and arterial grafts. So before sternal re-entry, we have to prepare your peripheral bypass. So you might consider femoral or axillary bypass. It is not unreasonable to harvest conduit before sternotomy, or make sure your assistant at least able to harvest a segment of vein before you go through the sternum. A common strategy for redo sternotomy, you cut the wire anteriorly and leave them in place. You use the oscillating saw to cut the outer table. The posterior wires are used to gauge the depth. Divide the anterior table with divide the inner table with a Mayo scissor and with meticulous dissection of the neighboring structures. Post sternotomy, avoid excessive manipulation of the vein graft, because it causes embolization if there is debris within the vein. Intra-pericardial dissection. When you reach the aorta, palpate it and look for evidence of atherosclerosis. It is not unreasonable to use an epi-aortic ultrasound. Regarding myocardial protection, use either antegrade or retrograde. Antegrade, there is risk of dissemination of the debris within the vein graft. It is ineffective for areas with in situ arterial graft. Regarding retrograde, you have to check for uniformity of your perfusion, coronary sinus pressure, uniformity of myocardial cooling, distension of the coronary venous system, and you have to occlude your arterial graft. So typically use a combo of both. You can induce with antegrade, and finish your induction dose using retrograde. And throughout the procedure, you give intermittent doses of retrograde cardioplegia. And it's not unreasonable once you bypass an occluded vessel is to give cardioplegia through a vein to that ischemic area too. Okay, potential disaster scenarios. Let's say there was a catastrophic hemorrhage. The first thing you do, you inform the OR team that there is a problem. You bring the sternal edges together. You may use a sharp towel clamp. You give heparin. You cannulate both femoral and arterial. You cannulate the femoral artery in vein. You go on bypass and start cooling. You may go on sucker bypass once the arterial cannula is in. For sucker bypass, you could potentially use 3 suckers. Use the regular pump sucker. You can turn your root vent to a sucker. And typically in most of the setup, there is an extra sucker. So you ask the perfusionist to prepare it. If you cannot achieve enough flows within sucker bypass, keep the lungs ventilated. That will help oxygenate some of the blood. So, LV distension due to VF. The scenario goes like this. So arterial structure is injured during sternal re-entry. Surgeon decided to cool down to 18 degrees and go to deep hypothermic circulatory arrest. As the temperature decreased, the heart starts to fibrillate and distend. If the heart is not well dissected, you might not appreciate that visually. The only way you could know is looking at the ECG, increase in the PA and LA pressure, and if there is a TEU probe, your anesthetist can tell you that the left ventricle is fibrillating. At that time, you shock the patient with the external pads and try to vent the left side of the heart. Can you guys tell me option of venting the heart?
So
right superior pulmonary vein. And
Okay, and then redo. What do you vent with that? How do you place your vent?
you mean the technique?
Yes.
Yeah, you retract the heart to the left side and identify the right superior pulmonary vein, put per string, and you put the vent there and guide it to the through the mitral to the left side.
Okay, so that carries a high risk of injuring important structure, and it's extremely difficult in a redo scenario to achieve.
Maybe through the apex directly?
You could do that. What's the problem with going through the apex?
You may
injure vessels.
Like what?
LAD.
Like the LAD.
And?
The patent lemma.
And? Patent is far away. The apex. What else?
PA.
No, we're still talking about direct LV vent. What could you structure injure with it going in blindly?
Mitral, aortic.
Exactly, mitral. And what other options?
PA, venting the PA.
Yeah. PA. So PA, it's easy and accessible in a redo. You could use it safely. What else?
Aortic root.
Left atrium appendage.
It's hard to see in the redo, but it's an option. What's the problem with the root? You could do it.
You need to do aortotomy.
For venting the root, no, you don't need an aortotomy. You need something else.
The root, because you don't want to do venting because your graft is there.
I understand, but venting the left ventricle through the root, what do you need? You need something for it to be effective.
After cross clamp,
exactly. So the root vent might not help you because it's only effective if you place a cross clamp. So in a redo scenario, I think the easiest and the easy accessible is the PA if you could see it. Or if you dissect it enough, you could go through the right upper pulmonary vein. Apex is really hard to get. unless you decided for a left thoracotomy approach to do your bypasses, so the apex is close to you. You guys have any questions?
One question regarding in the redo cases, and you prefer to keep the femoral open, or just to put like arterial cannula in the arterial line in femoral artery, or just leave it alone, because there is different surgeon and different preference?
So generally, old school surgeon will tell you they want to cut down, exposing both femoral and vein, and controlling these vessels with vessel loop, and maybe even placing a purse string. You could do that. Nobody's gonna fault you. What I might do is, through an ultrasound, I'll place wires.
Okay.
You can place ultrasound guided, place a wire at the common femoral, a wire at the vein, and have ready your percutaneous cannulas if you want to avoid the cut down.
Okay.
So you could do that. So it's not unheard of, just before you do your sternotomy, place an ultrasound, place 2 wires, and leave them inside. If needed, just do a percutaneous cannulation. It shouldn't take you long.
Yes.
Okay. So we talked about that. Okay. Injury to patent lemma prevalence is between 1 to 5%. It's associated with intraoperative mortality between 8 to 12%. Strategy to restore blood flow to the LAD. You could just ligate the lemma and do a vein. You could fix the stump of the lemma using a vein graft, or connect it to a vein graft. You could place a vein to the LAD while you repair your lemma. You can attach the stump of the lemma to another arterial graft if it's long enough. You could attach the lemma stump to the aorta. You could primarily repair the lemma with a rema segment. Or easily, which is I've seen done multiple times, if you injured the lemma, just place a shunt. Going through it, just place a shunt. This is my preference if possible. And then to fix the shunt in place, you can place bulldogs, distal and proximal to your injury site, while you figure out a strategy to prepare your lemma.
Shunt, you mean in the coronary itself?
Yeah, intracoronary shunt, yes. So the biggest shunt I think we have is around 2 millimeters. Just use the biggest shunt.
Yes. And
fix it in place distal and proximal using bulldogs. And then and it will give you enough time to think what is your best option. Either primary repair it, do an interposition graft with another arterial graft like radial or a vein graft or the rema, or maybe mobilize it further and see if you could attach it to another graft in a Y fashion, or mobilize it enough to attach it directly to the aorta. Clear?
Sorry. No, sorry. So the shunt will be, so I injure lemma, so I will put the shunt on the lemma.
Yes, inside the lumen of the lemma.
Okay. No, sorry. Then when I heard shunt, I was thinking about coronary. So
no. You're away. You're doing your left sternal dissection. Through the fat, you injured it. There's a hole.
And then bulldog, distal and proximal, so no bleeding.
Just to fix the shunt and spot, you could use bulldog. You can tie it to whatever is easier. But usually bulldog is tying a vessel. You need to go around it. At that time, there is not enough room. Like you did not dissect enough to tie it. So just place bulldogs. Make sure there is blood going through the shunt to the distal to your injury site, and then hopefully it works out, and then you figure out a plan how to fix it.
Okay, thank you.
Okay, preventing injury to the lemma. In the initial surgery, open the pleura and make a vertical slit in the posterior direction, just lateral to the thoropulmonary artery at the point where the graft naturally enters the pericardium. The rema graft is routed into the pericardium through the slit and lies in a posterior position, just anterior to the phrenic nerve and lateral to the pulmonary artery. if that was not done in the initial surgery and the lima is in the midline and you don't want to injure it, another option is you can cool down the patient to 28 degrees if you cannot dissect it and clamp it. And everybody knows this. I think most of our surgeons here do that. So that's why it's important to make a slit. Once the mammary lays in that slit, make sure that the lung does not push the mammary and the lung lies above it. Is that clear?
Yes.
So preoperative prevention strategies. So timing of surgery. The closer you are to the initial surgery, the higher risk, the dense the adhesion and high risk of re-entry. Optimal time is more than 6 months, I think, at least. The longer you're away from the initial surgery, the better. Be aware of history of radiation because adhesion take longer to mature. Before going ahead, you have to do all the imaging that we talked about earlier. You have to do your x-rays, CT, MRI, do a coronary angiogram with ultrasound mapping of your conduit. The aim of this imaging is to know for each bypass graft, we must understand it's important to the myocardial perfusion, understanding at risk for sustaining injury, devise a rescue plan should an injury occurs. At the operating room, you should brief the team on your surgical plan, which include cannulation strategy, cardiac and cerebral protection, LV venting, extra pump suction, structures at risk, expected action should a particular injury occurs. So before sewing the sternum, open the epigastric fascia, dissect the anterior heart away from the chest wall. What do I mean by that? As you could extend your skin incision inferiorly up to the epigastric fascia. You could divide the xiphoid if it was not divided priorly in the initial surgery. You could use rakes to lift the sternum. With direct vision inferiorly, you could use blunt dissection to gently separate the anterior right ventricle away from the posterior table of the sternum. During sternal re-entry, do not stop ventilating the lung. And you have 3 options. Option 1, you could untwist the wire and keep them in situ. Use an oscillating saw to divide the anterior table of the sternum. Use sharp scissors to divide the posterior table. And this is my preferred option myself. Option 2, you can take all the sternal wires, divide the anterior sternal table with an oscillating saw, divide the posterior table with a scissor or a lepchi knife. Option 3, you can take all the sternal wires, divide the anterior and posterior table with an oscillating saw directly. Once you open the sternum, your objective of dissecting the heart is first, you have to release the pericardium. Once you start your dissection, you have prepared cannulation and cardioplegia site and mobilize the heart to allow grafting of different target vessels. And the last part could be achieved on pump. You start with the light sternal release, stay close to the chest wall, start from the diaphragm surface toward the right atrium and the aorta. The reason for that, it's easy to identify your dissection plane at the diaphragm level. It's always advisable to look at an edge of pericardium and try to go to a plane between that edge and the heart. Make sure you don't dissect in fat. If you start dissecting in fat, there's a high chance you're dissecting through the heart itself. Be aware if there is a vein graft on the right side, the adhesions will be extremely dense. And it is okay to open the right pleura, and where you could feel that the vein is attached to the right atrial wall, you could keep a piece of pericardium on top of it and just go around it at the level of the SVC. You can re-enter the pericardial cavity at the level of the SVC and start dissecting laterally the aorta. Make sure you are in the correct plane without removing the adventitia of the aorta. That will just weaken your aorta. And the aim with this dissection is to have enough space for cannulation in case a disaster happens. Any questions?
No, clear.
Oh, thank you.
Okay. Left sternal release, stay close to the chest wall. Beware of the vision of the patent ITA. The space lateral to the aorta and above the pulmonary artery may be exposed to allow safe aortic clamping. At that time, at that stage, you could place your purse string, give heparin if you didn't, go on bypass, and then dissect the rest of the heart on pump. So what do you do with the patent lima? You could identify it and clamp it, or you could go with a no-touch technique with a continuous current perfusion. Continuous current perfusion with systemic hyperkalemia, give initial bolus of antegrade cold cardioplegia, keep your systemic potassium above 7 with boluses of potassium chloride around 40 milliequivalent each bolus. So outcomes, early mortality is between 6.9 to 11.4%. In the case of an emergency redo, is around 16.4 to 25%. If we compare this to the STS database, we could say that you could see that the mortality from all procedures around 3.5%, and from primary operation is around 1.5%. The main cause of mortality is preoperative MI in 85% of the cases. What caused that is incomplete revascularization, vein graft thrombosis, internal memory artery graft failure, embolic phenomena from the vein graft, injury to patent graft, and hypoperfusion syndrome. Predictors of mortality is peripheral vascular disease, diabetes, anginal status, and preoperative MI. Risk factor of mortality is LV dysfunction, large number of atherosclerotic graft, absence of IMA graft, preoperative NYHA class 3 to 4, time interval between primary CABG and redo. If it's less than 1 year, mortality ranges between 21 to 28%. If it's between a year and 10, ranges between 6 and 8.4%. If it's more than 10 years, is around 17.6%. If you decided just to go with antegrade, you have a mortality around 5.4%. If you went with retrograde, you have a less chance of in-hospital mortality, which is around 2.5%.
So if there is no lima, that will be better for the patient and the initial surgery?
Risk factors, absence of IMA graft. What do you mean? I didn't understand.
I thought that if we use the lima in the first surgery, that will be more risky to go for redo CABG because injury to the lima.
No risk factor, Yahsen, for redo CABG, that you didn't use lima.
Oh, okay, sorry.
Okay,
So, Dr. Abdullah.
shukran. So, multiple reoperation in hospital. If you do more than a once redo CABG, your in-hospital mortality is around 9.8%. Preoperative MI is around 8.8%. Your 5-field survival is ranged between 76 to 79%. Your 10-year survival is around 59%. Predictor of mortality is old age and low ejection fraction. And these data is mostly from Cleveland because they had the highest number of redo CABGs. Anyway, overall survival at 5 years around 76% and 10 years around 55%. Risk factor of that would reduce your survival is old age, impaired LV function, hypertension, diabetes, congestive heart failure, emergency surgery, and female gender. Okay, other alternative. What you could do if you decided not to do a conventional redo CABG, and the coronary is not amenable to PCI, you could use off pump, especially if a lima was not used. With off pump, there is evidence of short hospital stay, lower rate of post-operative transfusion, shorter ventilatory time, and lower rate of post-operative AFib. You could go with a different approach if reduced sternotomy is high risk. Like, for example, the patient has a patent lima to the LED. It's a big lima and it's directly below your sternum. You could bypass the lateral wall vessel, which are the circumflex and distal right, through left posterior lateral thoracotomy. You can access them. You could access the distal LAD through a left anterior thoracotomy. Regarding your proximal anastomosis, you could attach them to the aorta using a partial occluding clap. If that is not accessible, you can attach them to the axilla, axillary or subclavian artery. And you have the choice of going on or off pump. Regarding mid-cap, it's a good option in the hand of an experienced surgeon. It's usually preferred in a single, if you are only bypassing one vessel. It can be commonly done on or off pump. Lima harvesting is extremely difficult due to the previous adhesion, but it's doable. Especially if you have the facility of using a robot, it will give you more flexibility in harvesting the lima. You go through an anterior thoracotomy to access the LED, typically at the fourth intercostal space. By doing that, you avoid the risk of reduced sternotomy and aortic cannulation. But as most of the studies that compares conventional surgery to mini surgery, there is no advantage in mortality, stroke, or MI. You guys have any questions?
Thank you from my side.
Okay. Do you want me to go ahead with off pump?
Yes.
Okay, let's go. So when off pump CABG was suggested, they had certain objective. Is they were hoping that they will reduce morbidity and mortality comparing to on pump. They wanted to be similar to CABG, meaning same number, location, and quality of the anastomosis. It is reproducible and easy to teach, and it always achieve complete revascularization. So there are certain things that you have to be aware surgical technique-wise if you decided to go with off pump. You have to be aware about patient conditioning, your incision, conduit harvest, anticoagulation, enucleation, visualization, and stabilization. So patient conditioning, for optimized hemodynamic, you should aim for a heart rate between 50 and 70. You should have normal systemic and pulmonary pressures, normal thermia. You have to have a normal level of electrolyte, and common tools that you could use to keep your blood pressure intact is either a Trendelenburg position, you could use vasopressor or anatrobes, and you could give IV fluids. To keep the temperature normal, you could use warm fluid, inhalational anesthetic warmer, you could raise the temperature of the OR, or you could use a bear hugger. Incision, midline sternotomy. You could do off pump through a midline sternotomy. You open the pericardium in a longitudinal fashion. You could tack the left side of the pericardium. What most of the off-pump surgeons do, they can even both open pleura so that you can safely rotate the heart with no resistance. Conduit harvest is similar to on pump. Lima is of a particular importance as usually the first graft to be done. Anticoagulation of pump CABG are thought to be thought to induce hypercoagulable state. You give a heparin dose ranging between 80 to 350 unit per kg and try to achieve a target ACT between 250 and 400. Enucleation, what does enucleation mean? That means that you are moving a structure without touching it. It is important to do a Lima to LED anastomosis. Requires minimal manipulation. It could be achieved with a deep pericardial anchoring stitch. Typically, you place it between the left upper and lower vein. Usually, we use 2O Vicryl. With that stitch, when you lift it upward, you rotate the heart toward yourself. You could easily access the LAD. And if you lift it even further, you can even access OM targets. If you do want to use that stitch, you could use a 4x8 gauze, placing them at the transverse sinus, and you can lift the heart with it too. Visualization, it could be achieved to visualize your target through rotating the table and using apical section. Usually the obtuse marginal branches are the most difficult to access. Apical suction is applied to the apex, which devoid of vessels. The blower mister can be used once the vessel is opened. This is an example of stabilizers, which the starfish and octopus. This is the starfish attached to the apex. So you lift the heart and use the octopus to stabilize the LAD. This is another setup if we decided to do an OM. So what are the chronografting steps? First, you apply the stabilizer and the positioner. Dissect out the coronary artery segment. Make an epicardial incision for your silastic tape. Insert the silastic tape, but don't snare. Proximal, where you're gonna do your anastomosis. Snare the silastic tape. Make your arteriotomy incision. Insert your intracoronary shunt, and then loosen your silastic tape. Complete your anastomosis as usual, and take out the intracoronary shunt just before your last bite. Grafting sequence, collateralized vessel is grafted first, and collateralizing vessel is grafted last. So what does that mean? If the RCA is occluded and the LAD is collateralizing the PDA, then PDA should be grafted first. Otherwise, setting the LAD to do your anastomosis will make the LAD and PDA territory ischemic.
Again, Doctor, again, معلش.
For example, you decided to do a CABG 2. There is a CTO RCA, and the PDA fills from collaterals from the LAD.
Okay.
At this time, it's better not to do your LAD anastomosis first. The reason for that, to do your LAD, you'll apply your silastic snares and occlude it for a short period of time to place your shunt. At that time, you'll cause ischemia to the LAD and PDA territory.
Okay.
Is that clear?
Yes.
Okay. So for your proximal anastomosis, you could use a partial clamp on the ascending aorta or a heartstring. I don't know if you guys seen a heartstring. Basically, it's in the ascending aorta, use an 11 blade, and then you insert that punch that you see here. It will apply like an umbrella-like structure with 2 strings. And that white thing, umbrella thingy, will prevent blood coming out of the ascending aorta. You could do safely your proximal anastomosis. And then before your last stitch, you can just pull the strings and it will unravel the umbrella. So looking at the literature, there is, I'll mention 2 studies. The famous study is the Ruby trial by Schroyer et al. It's an RCT, single-blinded. It included 2,203 patients. It compared on-pump versus off-pump in an isolated CABG patient. Primary outcome, in the short term, was death or major complication, which include reoperation, new mechanical support cardiac arrest, coma, stroke, or renal failure on dialysis within the first 30 days. A long term, they looked at all-cause mortality at 1 year, non-fatal MI between 30 days and 1 year, or repeat revascularization between 30 days and 1 year. So short term, there was no difference, but when you look at long term, it favors on pump. When you look at the angiographic test, comparing on pump to off pump, there were more occluded graft on off pump, and graft patency was much less on the off pump group, especially veins. And do you guys know the main critique of this trial?
Yes. Not experts that many residents they are doing the off pump, and no experienced surgeon was doing the off pump.
Exactly, exactly. So based on that, the coronary trial was designed, and it was one of the first expertise-based randomization, and they had only expert surgeons are allowed to participate in the study. It's an RCT with blinded educated outcome assessment. It compares on pump and off pump in isolated CABG patient, and included around 4,600 patients. They had a co-primary outcome, one, composite of death, non-fatal stroke, non-fatal MI, and renal failure. Two is number 1 plus repeat vascularization at 5 years. Secondary outcome, they looked at blood transfusion, recurrent angina, death to cardiovascular causes, and it was published twice at 30 days and at 5 years. So at 5-year outcome, you could see there was no difference between the two groups. Okay. So I just talked about 2 big RCTs. One showed that off pump is worse, and the second, a well-designed RCT with relatively sufficient time of follow-up that showed no difference. So why do we still do off pump? Do you guys know?
Yes. So off pump is to do off pump according to the guideline. You have a class 1 indication to do off pump if you have a porcelain aorta. At that time, you need to go and to do off pump, either complete revascularization or at least the one you can do Lima LAD on the right side, because CERC is most difficult and can lead to hemodynamic stability. Class 2A in the European guideline 2018 is to do off pump in high risk patient, patient with renal failure. They define high risk as patient with not renal failure, actually renal failure, chronic kidney disease, risk of stroke, and COPD patient as well, because to avoid the cardiopulmonary bypass. This is exactly what mentioned in the guideline.
Exactly, and this is based on first expertise experience. It's also based on these RCTs. If you go dig in the data of especially the coronary trial, you notice there's if you do a subgroup analysis, the patient with chronic kidney disease pre-dialysis, they might benefit from off pump, just not to tip them toward dialysis. Another patient group is patients with chronic lung disease. We know by looking at the literature that off pump has less ventilation time in your ICU. Lastly, patients with bad ventricles. There is a benefit in avoiding cross-clamping the heart and causing ischemia if you can safely do your distal anastomosis. So who will benefit from off pump? As you guys mentioned, patient with heavily calcified aorta, aortic disease with risk of dissection, rupture, and embolization, impaired LV ventricular function, history of TIAs and stroke, chronic kidney disease pre-dialysis, and a patient who refused prior perfusion. This is not a big issue in our part of the world, but in North America, there is a religious group, they call them Jehovah's Witness. This group of patients, they refused blood transfusion and blood products in generally. Okay. You guys have any questions?
In meta-analysis, Dr. Abdullah, regarding on-pump, off-pump, what I recall in, and also OPCABI trial, which is designed specifically for the high-risk group, but the conclusion that, as they mentioned in the guideline, high-risk group of patients, and also they found that the problem or the issue, let's say problem, with the off-pump is less, not complete revascularization.
That's
Would you
true.
like to comment more about this?
So when you operate, you always face with the decision of bypassing a small target. If you have a vessel, which is the size is around 1 to 1.5 millimeter, and you want to bypass it off pump, you would do that anastomosis distally away from its origin. That result in a small, even a smaller vessel, and doing it in off pump, you have higher chance of not doing a good anastomosis, and you might take the back wall, and especially in a small vessel. If you go on pump, you have the luxury of going really proximal to the origin of that targeted vessel. You can open it and take your time doing your anastomosis. So off pump surgery, people tend to shy less in doing a small target because typically your anastomosis is distal than comparing to on pump. And you have a beating heart. Is that clear?
Yes.
So you could see, you see OM2, it's calcified, it's tight, you're not sure. Usually they sect it even closer to the left AV groove. Yes. You might find a softer spot, maybe slightly bigger, and you can do your anastomosis. This you cannot do with off pump. You cannot, it's not a luxury. And I think that's the main reason.
Because of the manipulation. I cannot do the same manipulation to expose it on the left atrial appendage.
Yes, it's just, I've never seen it. I don't know if you could do it. Maybe an expert off-pump surgeon claimed he can do it, but I've never seen it. I think it's extremely difficult. Because think about it. If you lift the heart, somehow you're gonna somehow prevent adequate filling of the ventricle. The higher you lift the heart, especially the right ventricle, you might fold it and prevent adequate filling. You'll just eventually drop your blood pressure. The more you lift the heart. Is that clear?
Yes.
I'm not worried about collapsing the left ventricle. I'm more worried about collapsing your right ventricle. Impaired venous return, that will cause hypertension.
Yeah, clear. Okay. What is, according to the, also a question about the CABG and arterial revascularization. And now we know that in guideline, the radial is a class 1 with severe stenotic, critical stenosis on the right, and more than 70% on the left side, and REMA is 2A.
Yes.
How you see it? The fluid for arterial revascularization. We know the ART trial, the subgroup analysis, intention to treat. Then now Roma trial is ongoing.
Exactly. People, let's go back to the LEMA.
Okay.
People start using it in the 1980s, but it was not popular. It's only proven that it's better than vein graft once we have long-term follow-up. Once it's proven that it's after 10 years, having a LEMA to the LED improve your survival and rate of revascularization is much less, then people cannot say no to a LEMA to the LED. And I think this will happen with the REMA eventually. The R trial, they just reported, if I recall correctly, 5-year result.
10 years. They just published 10 years, and they found generally no difference, but in the intention to treat analysis, there is a benefits of off-pump because of the crossover for 14% they found.
Okay.
Also, they found, I think, 21% in the single, not bilateral, they have a radial, which being proven in the meta-analysis to be superior to the vein graft.
So this is known, but I think REMA has a benefit, but we have to have longer follow-up time, 10-year plus, at least. Plus, you have to make a decision. The next question would be, is the REMA better on the left or right system for long-term survival? This is another question that may rise in the future. So another question that may, let's say, our trial, they published their 15-year result and there is definite benefit of the REMA. I'm not aware of the design of the Roma trial, but at that time, some surgeon who doubt total arterial, they might question, is it better on the right side or the left side? So this is a question that we have to answer in the future, but I'm a believer if there is good left system targets, like a good OM and an LAD, you should use both BMS or both arterial IMEs.
Okay.
Okay. Done now. Okay. Go through them quickly. To improve survival, we'll just read the class 1 CABGs. To improve survival is recommended for patients with a significant more than 50% left main stenosis. To improve survival for non-left main, CABG to improve survival is beneficial in patients with significant more than 70% stenosis in 3 major coronary artery with or without involvement of the proximal LAD, or in the proximal LAD plus 1 or other major coronary artery. This is fine. CABG or PCI to improve symptom is beneficial in patient with 1 or more significant coronary artery stenosis and enable to revascularization with unacceptable angina despite guideline-directed medical therapy. Okay, this is important. Preoperative antiplatelet aspirin should be administered to CABG patient preoperatively. In patients prepared for elective CABG, clopidogrel and ticagrelor should be discontinued for at least 5 days before surgery, and prasugrel for at least 7 days to limit blood transfusion. And patients referred for urgent CABG, clopidogrel and ticagrelor should be discontinued for at least 24 hours to reduce the major bleeding complication. In patients referred for CABG, short-acting intravenous glycoprotein 2B3A inhibitor could be given and discontinued 2 to 4 hours before surgery. Abixibam for at least 12 hours beforehand to limit blood loss of transfusion. Yes, you guys know that. Use of antiplatelet post CABG. There's always evidence of using aspirin. 2A, you could use Plavix if the patient developed if the patient has aspirin allergies. This is what I currently do in my practice. I follow the Canadian guidelines. What I like to do is dual antiplatelet for at least 1 month post-CABG with patient with ACS. Regarding carotid screening, they recommend a multidisciplinary team approach to look at the need for carotid screening. Carotid artery Doppler scanning is reasonable in selected patients who are considered to have high-risk features, for example, old age, left main, peripheral vascular disease, history of strokes, hypertension, smoking, and diabetes. In CABG patient with previous TIA or stroke and a significant 55 to 95% carotid artery stenosis, it is reasonable to consider carotid revascularization in conjunction with CABG. In such an individual, the sequence and timing of the carotid intervention in CABG should be determined by the patient's relative magnitude of cerebral or myocardial dysfunction. Is that clear? Do you guys have any questions?
Yes. Doctor, carotid broe by guideline, it's not indicated for ultrasound, right?
No, no. So it depend on your center practice. For example, here in the Babtain, we scan everybody who goes for CABG typically. But the way I was trained is either if the patient high risk features or history of TIA, we don't scan them.
Okay.
Okay, where is that? Finish that. And then carotid endarterectomy, you know, you guys either do it before or after. I'm not a big fan of doing it at the same time. So conduit, it's clear, just use Lima to the LAD, and Haitham, I think you talked about that. Use an artery graft may be reasonable when grafting the left side of coronaries with a severe stenosis more than 70%. Right-sided artery with a critical stenosis more than 90%.
Doctor?
No.
You are not big fan of doing carotid endarterectomy with the CABG for which?
Absolutely. If the patient, let's say you have a patient who came to your clinic with stable angina, secondary to left main around 70%, and he has a proximal RCA disease. The patient had history of TIA with a 99% occluded right carotid, and the left is around 50%. At that time, you have to make a decision. Either you want to do the CABG first or the endarterectomy based on the patient's symptoms. If the patient suffers from TIAs more, and you think it's safe to go with that, you could go first. If you think the left knee is more important, then do that first. If you decided to do them both, it's a big ordeal. So what typically you could do, you could position the patient. You can ask your vascular colleague to do the right carotid endarterectomy, and then you could repair it with a patch, and they would give heparin at that time. You should not close that wound and leave it open and pack it. Proceed with your sternotomy and conduit harvesting, and then at closure, you can ask your vascular colleague to come back and repair them. It's a very complex thing of doing stuff, and there is always risk of stroke. If you could avoid it, I prefer.
Yes, and if you kindly allow me just to add, recently in 2019, it was published also meta-analysis following patient. They did combined CABG plus carotid, and they found that long-term mortality is the same. However, short and mid-term, the combined procedure associated with more morbidity and mortality. But long-term is the same. So agree, yani, even the data supporting that, avoid it if you can.
And, this is probably it's a systematic review looking at probably mostly observational studies. Is that correct?
Yes.
Or there's some RCTs. So, Anyways, acute MI. Do you guys know, can you guys tell me class 1 indication to operate on an acute MI?
If it is not amenable to PCI, STEMI.
Correct.
First of all, STEMI, non-STEMI, and the acute MI. STEMI, it's preferred to do fibrinolytic therapy or PCI for different reasons. You restore perfusion quicker. And but if it is not amenable, so at that time, emergency CABG came as class 1, or you have acute MI, STEMI or non-STEMI, but with mechanical complication. Otherwise, go with the PCI for STEMI.
Do you know, guys,
from the cath lab?
That's true. What's the mortality if they cannot open a STEMI with a PCI when you decide to take him?
It's high. It's around 30%.
Exactly. Okay. So this is probably mentioned here in details. What I want to highlight is this. emergency CABG should not be performed in patient with persistent angina and small area of viral myocardium who are stable hemodynamically. Emergency CABG should not be performed in patient with no flow phenomena. Do you guys know what that means?
No flow phenomena. Yes,
Yeah.
when you lower rib refusion injury, and that can lead to because of the edema that happened because of the ischemia, then you reestablish the flow because of the high I think venous pressure and the edema around the vessels. You have a flow from your graft, but the bed, the vascular bed cannot be rib refused. I'm not. If I'm wrong, anyone can correct me.
So emergency, this is patient at the cath lab. Emergency CABG should not be performed in patient with no flow. So after a successful PTCA, you could see, let's say, TEMI2 flow, but the patient still have ongoing ischemia. This ischemia is probably to the debris occluding your microvascular vessels. So doing a CABG on him, you're not going to help that patient. Is that clear? That sometimes happens. Even when you open a vessel, you can still have ongoing ischemia. So you just manage him medically. Let's see what happens.
So you mean there is a flow, but there is something else occluded the
Yes.
small branches. Okay.
Yes.
So even if we take this patient, we will not add anything to him.
No, you're just going to kill him.
And is it because of the edema that happened?
No. This is, let's say you have a patient who came with inferior STEMI, a very heavily calcified RCA. They decided to open it with a stent. They had good flow, but the patient's ST segment did not settle down. And the patient still have ongoing troponin leak. So that's so you just place a balloon pump, give him anticoagulation, and wait on him, see how he behaves.
Okay.
Because angiographically, you could see there is good flow. Okay, let's go. So after failed PCI, emergency CABG is recommended after a failed PCI in the presence of ongoing ischemia or threatened occlusion with substantial myocardial at risk. Emergency CABG is recommended after a failed PCI for hemodynamic compromise in patient without impairment of the coagulation system and without a previous sternotomy. Emergency CABG should not be performed after a failed PCI in the absence of ischemia or threatened occlusion. Emergency CABG should not be performed after a failed PCI if revascularization is impossible because of the target anatomy or no flow state. So having said all of that, you guys notice there is just little indication for emergency CABG. Okay. So anyways, you bypass targets if the left main, so you can do a CABG if you're planning to do an AVR, for example, if the left main is more than 50% and other targeted vessel more than 70. We talked about this. I think that's about it. Okay. Do you guys have any questions?
Doctor, what's the window of taking patient for emergency CABG? And Lawrence, it's mentioned it's hours. If you cannot take him within 6 hours, you have or you should wait for 1 week. Between 6 hours and 1 week is high mortality. But in literature, it showed whatever the time you take him for the emergency CABG, it's high mortality. It's not depend on the time, it's depend on the patient condition and comorbidity.
So I agree with you. So you only take him after an MI if his symptom did not settle and they cannot open him with PCI and you think you can bypass him safely, regardless of the time. Is that clear? Let's say the patient came at midnight. He has proximal LAD, he has a mid-circumflex disease, with a good OM target, and he has a proximal RCA. He came with a lateral MI. The culprit is the mid circumflex. So they open it with a balloon, but it's calcified, and the cardiologist was worried that he doesn't want to place a stent there. You get good flow phenomena, and you say, you know what? Well, let's observe the patient. If the patient's symptoms still persist after 24 hours, let's say, and you decided to take him for CABG, take him for CABG. Don't wait, because he has ongoing ischemia, accepting high risk. If the patient settled, you have to wait for a week. You have less mortality. It's proven. So this is in practice, because 6 hours, it's not, you know, it's not our usual practice. Usually our intervention cardiologists, they try to open it with a balloon or a stent, and by the time you decide to take him, will be more than 6 hours. But if you strongly believe that the patient have ongoing ischemia, PCI failed, then just take him, accepting high risk. Because your patient has no other option. Either you leave him to have his MI and end up with heart failure or death, or you just revascularize him. Is that clear?
Yes. And
okay,
one more question, the last one. And STEMIM guideline, they mention the BCI is more beneficial if it's done less than 12 hours or with 12-hour window from the starting of chest pain.
Okay.
That's applied to our patient also if they fail to open, if it's presented 15 or 16 hours after from onset of chest pain and they cannot open the fizzles. There is any rule of do revascularization of this patient, or it's too late for him?
No, for non-ST or ST?
ST.
I would take him if he has a reasonable target with ongoing pain. I wouldn't wait.
Okay.
So I don't know. I wouldn't. I will just, if he has reasonable target, and you think you can do safely the surgery, accepting higher risk, and I'm assuming he's already received the loading dose Plavix or ticagrelor, so you have to be clear with the patient. High risk of bleeding, high risk of mortality. If he accepts it, just take the patient, and then deal with the complication afterwards. Yeah.
Dr. Abdullah, kindly, when you mentioning the high risk meaning, from what I understand, that patient is hemodynamically unstable, acute kidney injury, acute liver injury, sky high TROP and sky high CK MB. Is this the what you mean by the accepting high risk? Because the mortality will be more.
Yes, absolutely. But you have to make sure you have good targets.
Plus the target. Okay.
Yes. Let's say a patient has really bad target or CTO everywhere with small distal target, you're probably not going to benefit him much going on. So it's a judgment call. If he has good target and you think you can safely bypass him or give him lima to the LAD, maybe a good OM graft, just take him.
Plus his general condition, young, this is old, frail, not frail.
Yes. Let's say there's a guy who has known chronic disease. He already had a previous stent, the RCA, multiple stent to the LAD. This guy continued to refuse surgery, developed congestive heart failure, ejection fraction of 20%. Eventually, he developed left bundle branch blocked, and they placed an ICD on him, or a CRT. And he doesn't take care of himself. He came, you know for a fact that he had multiple intervention to the right, LAD. He came with a STEMI. When they did an angiogram on him, you found that the LAD, there is evidence of instant restenosis. The right was severely diseased and it failed PCI multiple times, and it is the culprit now. And the circumflex has a new lesion. So you have LED that's been intervened multiple times. Target is questionable. The right is really bad. And there is a new OM that they believe is the cause of his MI. I wouldn't take that guy. The reason for that, the LED has been intervened multiple times. The distal target is questionable. The right, is almost gone from repeat intervention. So the only thing I could see to bypass maybe the new OM disease. So I'm not gonna take a patient with low ejection fraction, ICD, questionable LED target, and the only thing viable is an OM, maybe with low ejection fraction. I would try to avoid taking for emergency CABG because his mortality is extremely high and I'm not sure if he would be able to come off bypass. Is that clear?
Yes.
Dr. Abdullah, how you judge the target anastomy patient with complete, let's say complete LAD occlusion with no collateral?
Okay, so if there is no collateral, that means it's an abrupt occlusion.
Yes.
You might ask nicely your cardiology colleague to try to wire it and balloon it and see if it's a thrombus and if there is a distal flow coming toward it. So I will ask him to balloon it, at least. ولا يحط wire through it. If they could not balloon it and the wire does not go through it, he has a dropped ejection fraction. The anterior wall does not move. And a thin anterior wall that tells me that the occlusion did not happen now. It happened long time ago. And there is evidence of Q wave in, let's say, the anterior leads. So at that time, although it's an abrupt occlusion, you assume it happened long time ago. And the reason there is no collateral is in the anterior wall ميت. It's all scar tissue. So you question. So you have to ask for more investigation before going ahead with CABG. You can ask for a viability step and viability studies and CTs. But if it's an abrupt occlusion that caused the STEMI, your cardiologist colleague could balloon it at least.
Okay, thank you.
Okay, so kindly, Dr. Abdullah, could you again please explain the reflow phenomena? Because maybe I understand it not well and it's really important.
Okay, there is a heavy calcified RCA.
Okay.
It's a bad vessel. A lot of calcium, it's beaded, not uniform. There was evidence of mid-RCA, looks 70% occlusion. When the patient came with NSTEMI and the cardiologist believed this is the culprit of his acute coronary syndrome for whatever reason. So he ballooned it and he restored TEMI 2 flow, for example, or TEMI 3. But the patient's symptom did not go away. And he still shows evidence of troponin leak. What that tells you, when they ballooned it and placed a stent, they may dislodge some of the debris that went distally and blocked the microcirculation. وضحت الفكرة؟
Yes.
So you have to know that information يعني. لو يكلمك الكارديولوجي يقول لك هيثم جانا المريض فاستمي فتحنا الرايت حطيت ستنت وما ادري ايش بس المريض لسه عنده symptoms وما اعتقد الستنت شغاله تعال خذه. You have to think about it before.
Yes.
Okay.
Thank you.
طيب الحين صلاة الظهر أنا عندي 3 we could do 3 orals 3 short cases. أنتم typically our exam 10 minutes for questions. في 20 دقيقة بيكون بس أنا والcandidate اللي معي. Unfortunately given the time ما مداني أجيب صور وما صور. So we have to use our imagination يعني.
Okay. خلاص موجود أنا I will start بعدين ممكن في حسين في عثمان في فيصل فما في مشكلة.
Okay, can we start?
Yes.
Okay. Our first patient was 60 years old gentleman with history of chest pain for a few hours. He came to the emergency department. Okay, history. What are you gonna ask?
First of all, I will come to the patient. I will introduce myself to him. Then in the history, I will ask about the onset of the chest pain, onset, duration, and the characteristic of the chest pain, and any associated symptoms with this chest pain that include shortness of breath, dizziness, or loss of consciousness that happen with it, radiation of the chest pain. Is it central, radiated to the shoulder, to the jaw, to the back? Then after characteristics of the pain.
Okay, can I hold you there? Can I hold you there?
Yes.
He tells you pain 6 hours ago, crushing in nature, mainly at the mid-sternum. That is associated with nausea and vomiting, and there is evidence of also jaw pain.
So from the pain that he described and his age, most likely, one of the differential diagnosis now in my mind is myocardial infarction. I will continue history with him. However, on the same time, need to connect him to the oxygen and to obtain the ECG while I'm doing my interviewing the patient, because I need to know his vital sign, if it is unstable or desatting, or the blood pressure that need to be intervened before completing the history. But first, this is important things, yani, for me just to have the ECG now for him before proceeding.
Patient oxygenation is acceptable. Aroma around 91%. It's tachycardic. Once you connect them to the lead, there is evidence of ST segment changes. Blood pressure is 100/60.
100/60. No ST elevation. No.
There is on the telemetry. There is ST changes. You're not sure. It's not clear.
Not sure. Okay. So I will just quickly ask him about if he's a smoker, diabetics, and if he have any history of dyslipidemia, any history of cardiac disease or known to have a cardiac disease, family history of cardiac disease. And then quickly about the history about allergy. And yes.
So he tells you briefly, I've been a smoker since I was a teenager. They told me I have diabetes, but I don't take my pills regularly. I ignore them. I'm not sure about my cholesterol, and in our family, a lot of my relatives had MIs.
Okay, so according to what the data that I have currently, the ST changing as well. So I will give him oxygen, one.
Good.
I will give him aspirin, loading dose 350. Clopidogrel as well, 300, and keep him on oxygen. And I will instruct the nurse every 5 minutes to do ECG on him, as well as I will send the troponin, CKMB, with CBC and chemistry, and liver function as well. Beta blocker, heart rate. I recall you told me is tachycardic, so also
120.
Yes, 120 with acceptable blood pressure. So beta blocker, morphine for his pain as well. Need to give him morphine for his pain, and quick bedside chest X-ray. And I will call the echo lab, or myself. I will just obtain quick view for the echo.
Before all of that, what you should ask for? Simple investigation. On the telemetry, there is evidence of ST changes. Only two. Let's say multiple.
So I need to repeat the ECG now.
So you need to do. We did not do an ECG. You just connect him to a monitor. المونيتور ما تعطيك الليد كلها.
I thought there is ECG. Okay. So I need the 12 lead ECG.
So the 12 lead ECG showed significant more than 2 millimeter ST changes in the anterior leads.
In the anterior lead. Okay, at this time, I will call the cath lab. I will activate the cath lab to shift the patient immediately from the ER to the cath lab. And
would you wait for echo or blood work?
No.
Yes, exactly. You could take them, you could order them, but don't wait.
Yeah,
okay.
Need to be door to the balloon 90 minutes.
Exactly. So luckily, your center has a cath lab. You talk to the cardiologist. Within 30 minutes, they set up the cath lab. They took the patient. The right was 100% occluded at midpoint, and there was a successful stenting with good NE3 flow to the PDA, but the patient has residual 70% distal left main disease. After the intervention, the patient's symptoms settled down, and he went to CCU.
Okay.
So what do you do at this time?
So this time, I will visit the patient in the CCU. Now he's stable. I will obtain full history from him in details, and physical examination, full blood work, including the CBC, cardiac enzyme, CKMB, renal and liver function test as well. Then I need to do a chest X-ray and echo, echo to check for ejection fraction, washer mode abnormality, and ejection fraction of the patient, any valvular pathology associated with his presentation. And after I have all the information, initially I will tell him that you have the you came with a culprit lesion that is RCA being fixed with a PCI. However, you have a left main disease, and that requires surgical intervention. But just we need to complete your workup, and after workup, I will come back to you to give you our surgical plan.
Okay, so troponin to be expected was positive with a CKMB. Blood work CBC as within normal, kidney function is within normal, liver function within normal, chest X-ray was relatively normal. Echocardiogram showed left ventricle impairment and decreased ejection fraction. His current calculated ejection fraction is around 45%. He has hypokinesis in the inferior and lateral wall of the left ventricle. The right ventricle is within normal function. There is trace mitral valve regurg. Otherwise, there is no significant valvular disease.
There is mitral valve, what? Severe?
Trace.
Okay. Trace MR. So I just need to follow up to review the angio for him to see the anatomy exactly of his left main, and if it is critical, I need to proceed. I will proceed with the CABG next day. Actually, if it is critical left main,
the patient symptoms settled.
I can.
The patient is stable. After reviewing it, he has 70% distal left main. That's it. 70%. Very good. OM target is a nice, a good juicy OM or a nice LED. But he's stable now. And he is on, he's on aspirin ticagrelor.
Okay, and CK will be high, troponin will be high.
So after a few days, they're trending down.
So I will I will plan CABG for him after explaining all risk and benefits for the CABG, especially he's a diabetic, and this is class 1 indication for CABG for him. And while now he's stable on monitoring on CCU, I will stop clopidogrel. I will continue on. I will leave him on aspirin. Then after 5 days, I will take him to the CABG.
Okay, the cardiologist tells you, Dr. Haytham, I cannot stop the ticagrelor. I just give him a drug-eluting stent. Are you crazy? He's gonna thrombose.
Okay, so at that time, I will also will operate on him while he's on ticagrelor actually.
So what's your plan? What are you gonna operate? What are you gonna do? How are you gonna deal with it?
I will just follow up troponin and CKMB level.
Trending down. He has zero chest pain. Trending down, he has zero chest pain.
Zero chest pain and trending down, but he has left main and
70%. 70%. That's it. That's the left main. 70%.
70% left main.
With no ECG changes. ECG on the pericardial lead or the normal?
Just within in the same admission, a third or fourth day, I will take him to do CABG.
Okay, based on the guideline, when should you go? When should you operate after a STEMI?
Based on the guideline, 3 months.
3? My guidelines have to be 3. When should you operate? The guy just had an ST elevation. فتحول القبض.
Okay. I'm not sure. I need to review actually that exactly after STEMI.
Yeah.
And the culprit was opened.
And it's only 70% left main. So, if the left main, if the anatomy is not high risk, and the cardiologist believes it's a stable lesion, you wait a month.
Okay.
If it is a very complex disc left main, including the proximal LAD, and you're not sure, wait a week.
Okay.
Generally. So let's say it's a stable, it's a very focal distal left main, 70% LAD, proximal is fine, circumflex is fine. Patient after a week, he's been really stable, and the cardiologist believes we can safely discharge the patient. When would you operate on him?
Electively, 1 to 3 months.
A month. I wouldn't wait more than a month. So he agrees, you talk to him, he agrees for surgery, he's stable now. He left the hospital with aspirin, ticagrelor, beta blocker of some sort, and a statin. And he started on his oral hypoglycemic that he was ignoring. So he left in a stable condition. And you scheduled him electively for CABG 9-2 in a month's time. So you already called your secretary, حطيته في الليسته حقتك قلت لها يا مريم, the first week of next month I want to operate on this guy, CABG 2. حط لي اياه في الليسته. What's your plan of managing his antiplatelets?
He has newly drug-eluting stents.
Yes.
There is actually, I was searching specifically for this information. but safely, I ask even multiple cardiologists, safely we can stop the antiplatelet safely 3 months, but we can push it to 1 month. After that, I can stop ticagrelor for him for 5 days. If he stop it at least 1 month.
Would you bridge him?
I would what? I cannot hear you.
Would you bridge him with short-acting antiplatelets?
It is class 2A or 2B, I recall. But
you could do that if you want. Yeah. Nobody's gonna fault you. Madam has 2A with a 2B. There is no harm. You could do it.
Yes, 2B, class 2B to bridge. Yes.
But if you decided to do it, then it might be logistically it's a little bit difficult. انك لازم تدخل المريض 5 days before his surgery. So bed will be an issue, but you could do that. Nobody's gonna fault you.
Yes. Also, I can ask for platelet function test if I want to be sure. Yani, during this period, there is no activity of his antiplatelet.
Yes, but fine. Anyways, so you brought the patient. After discussing with your cardiologist, they told you, hey, you know, it's fine. You just stop his ticagrelor يومين 3 أيام. كلمته قلت له خلاص يا فلان وقف التيكاجرور يوم الجمعة الصباح ندخلك السبت وعملية الاثنين. دخل السبت يوم الأحد الصباح سويت function test أو ADD طلع acceptable result and you decided to operate on him on Monday. Okay. So you know you went on bypass. فتحت السترنم, you took your mammary, you decided just to take a vein لأنه هو diabetic, قلت you know what ما راح أحط arterial, I'll just keep it simple, and you did a CABG 2 on the guy. You came off pump, and after protabine there was really evidence of coagulopathy. You cannot see clots. What product should you give, or ask your anesthetist to give?
At this time, I'm giving the history that he was on ticagrelor. So the first things in my mind that he need to receive platelet.
So he got tons of platelets. Helped him. He started to clot a bit. They did the rotem for you. طلع عنده يحتاج شوية FFP, شوية cryo. أو يعني coagulation was not optimum. يعني it's better, but you're still struggling. يعني you're not 100% comfortable closing the chest. What would you consider يعني?
So the consideration at that time, if it's really coagulopathy, I can first after giving all the product, excluding all the surgical site bleeding.
There is no surgical site bleeding. You reviewed your surgical site 5 times.
Okay, I will just wait, do packing. If it's still coagulopathic, they have the option to shift the patient on to the ICU, intubated with the open chest.
So you packed. Jack الانستيست عطاك more platelets. It seems reasonable يعني. فكرت قلت you know what, خلنا نعطيه more platelets. أعطيته another 12 units. Looked reasonable. You said you know what, to avoid infection with diabetic بسكر الجسم. So you close the chest. وقلت لهم just make sure you milk the tube so he doesn't clot. وإن شاء الله eventually coagulopathy will get better by tomorrow إن شاء الله. So he went. وانت طبعا you had a very long day and you're extremely tired. ورحت البيت على اذان المغرب كذا. So توك جالس you're having dinner with your family. كلموك الاي سي يو قالوا لك the patient is unstable with ST elevations and inferior leads. What are you gonna do? What do you think of and what you want to do?
ST elevation, inferior lead. That means he has recent stent and they give him a lot of platelet and cryo and FFB. That means it could be occlusion. occlusion of the stent that he did in the RCA one. But I need just to ask I will go, of course, to the hospital immediately, but I need also to be sure there is no tamponade, evidence of tamponade. Also,
no
at the same time.
No tamponade. Your intensivist, عمل bedside echo. He didn't see major clots, but he could see clearly, and the inferior wall is akinetic. The patient is getting hypotensive severely. You came off with only a small dose of norepinephrine. Now the patient is on the 3 anatropes to maintain a blood pressure. What are you gonna do?
Yeah, immediately I need to activate the cath lab, and it is better if I have a hybrid room in the hospital. We have actually in our hospital the hybrid room, just to check all the coronaries. Especially my mind is going for the RCA.
Okay, so you have the privilege of a hybrid room, which is ideal. I agree with you. If you took the patient to the hybrid room, you already set up for a possibility of an emergency exploration and a CABG. Your pump is ready, everything is ready. CR حطوها قريب من البيد وجاك الانترفنشنست وهي shot الانجيوجرام showed that your LAD is patent, your OM graft is good and patent with good flow, but there is 100% occlusion of the stent. What would you advise the cardiologist to do at that time?
Okay, at that time I will ask actually their help if they can open that occlusion of the stent. Most likely, it could be a thrombus formation due to the blood product. So they can do aspiration through the cath, and if they can what they call it, balloon it or solve this problem or not. Technically, I'm not.
قال لك الكارديولوجيست بعطي تكاجرور بولس. Would you agree, or you want to hold? What are you going to do?
No, I will agree.
Okay. So he through the NG tube عطى another dose of ticagrelor. دخل. He was able to suction the clot, reasonable reflow, and and then you struggled with coagulopathy for another 24 to 48 hours. Eventually, you were able to close the patient. Now, let's say the next time you had to open him after the ticagrelor, he bled, you packed him. But you know what? We're not going to aggressively manage his coagulopathy. We'll just wait it out. After 48 hours, he settled and you closed him. Eventually, he was extubated, and went home. But he came back to you after a few weeks with deep intestinitis. Then you have to deal with it. Okay, خلصنا الكيس. Do you guys have any questions?
I want to ask a technical question. Why they stent the RCA?
Japanese, an anterior elevation myocardial infarction. So they have.
Yeah, they should balloon it, open the calibrate lesion, and there is left main. They saw the left main. They open the calibrate region, and we will take we will do the rest.
So depending on your cardiologist, they could balloon it or they could stent it. It's up to them. I would not fault a cardiologist for stenting a lesion. I would not fault him. But
So you are with ballooning?
Ballooning, if he gets good result.
Yes.
If he stent it, I will not fault him. ما راح أقول له ليش حطيت الستنت. ما راح أزعل منه يعني.
Okay.
ما راح أزعل منه. But having said that, I will accept the risk of bleeding or possible of stent thrombosis. Yeah.
And you will not graft that in OR?
No, I wouldn't. It's competitive flow. There's no point. خاصة إذا بتحط فين عليه. I wouldn't. Yeah. I wouldn't. Because sometimes you're lucky you can get away with it. Yeah. You might not have much bleeding وتقدر تسكره. Or let's say in a different scenario, you stop the catheter 3-4 days. The patient عنده good delicious function test. You take him, you came off bypass, he's not bleeding, everything looks great. وبعدين after 6 hours قلت لهم في الاي سي يو عطوا تكاكرول خلاص. إذا chest tubes are closed, you might get away with it in a different way يعني. فاهم قصدي؟ A different way, in a positive way, you do the same thing, but you're lucky in coming off bypass after proximal, everything looks great. ذكرته وبعد 6 ساعات chest tube does not head بس رجعوا له تكاكرول. And everything goes well and patient يروح البيت day 5. No issues, zero.
And in the second,
happened too.
and in the, yes, and in the second scenario, still you will ask them to aspirate the clot to, and
No.
fix.
Second scenario, there is nothing happened. Everything went perfectly.
No. I meant when the
yes, I would.
when the stent include. Sorry.
Yeah.
تفضل.
Yes, I would prefer if they can suction it. لأن لو حطوا لك stent ثاني يعني more thrombosis.
But you will not take him for a new graft.
People would argue you could do a bypass. Nobody's gonna fault you. Nobody's gonna fault you. You can. At this time, it's a judgment call. إذا أنت شفت الRB is cocked وأنت you think opening it with a stent is better than going bypass, and أنت you have to cross clapping, صح?
Yes.
If you think you restore flow faster, I would go with PCI, accepting the bleeding. لا حول ولا. If راح ولعب فيها وما قدر يفتحها, you have no other choice. You have to go for CABG.
Okay.
الكيس الثانية. Okay. Who's want to do the second case?
I will.
Same?
Yes.
عرفني عنك أحسن شوي.
أنا اسمي حسين القطان، I'm R7 في مستشفى الملك خالد الجامعي، جامعة الملك سعود.
Great. Okay. Case is an 8-year-old woman who presented with acute coronary syndrome. شافوها الكارديولوجيست جاية في الرياض، جاية let's say من الخرج، جت acute coronary syndrome. They diagnosed her with NSTEMI, they managed her with isoflavix, stabilized her, وحولوها عندكم في الجامعي، جابوها من الجامعي، جت الجامعي، جت الكارديولوجيست كذا day 4 after NSTEMI عمل لها angiogram. طلع عندها distal RCA disease around 70%.
Okay.
With a good TDA target. عندها severe distal left main around 90% with 70% proximal LAD disease.
So first of all, I have to take more history about the presenting illness. I need more history about the comorbidity, diabetes, hypertension, history of a stroke, history of COPD, any previous surgery on, any previous intervention in the heart, any previous stenting, any previous surgery in the heart, and history of to take the decision if patient will fit for surgery or not. Kidney disease, stroke, infection, peripheral vascular disease.
So she's an 8-year-old lady, will go from head to toe. She got a stroke 10 years ago. She recovered from it.
She recovered totally, okay.
She recovered from it. She's otherwise okay. She regained function. Lung-wise, she has no issues. She's never smoked. She's fine. Before heart-wise, before this incident, she never had a heart attack before.
Okay.
Ever. GI, she has no dysfunction. Kidney, she has evidence of chronic kidney disease. Her GFR is not that bad. Let's say 60. Fixed.
Okay.
No evidence of known peripheral vascular disease, but she's not that active. She's been diabetic for more than 60 years, hypertensive for as long as she remembered. But she takes statins, but she never knew that she has high cholesterol yet.
So
What do you want to else ask about
I
that
need
medical?
more detail to determine her STS score and frailty.
So what frailty index do you use?
The seven criteria plus the walking test: independent and toileting, bathing, clothing, urinary incontinence, and feeding. And walking test, if she can able to walk without assistance, and to take 6 steps in 6 seconds. And I have to assess muscle wasting, body textures, and and I may order some lab for her to just see the malnourished and pre-albumin, total iron, something like this, just to assess she will be fit for surgery.
So she tells you lady أنا لي 10 سنين غرفتي في الدور الأول، ما عندي مشاكل الصباح أصحي أنظف نفسي بالحمام أغير أسوي لي كوب شاي والبنات يطبخوا لي walking wise عندها severe osteoarthritis both knees ما عملت knee replacement. She used a cane to mobilize around the house وتقول لك يا ولدي آخر 10 سنين أنا I barely get out of the house يعني ما أروح إلا أزور أقاربي والعزايم غير كذا أغلب وقتي في البيت ما أطلع يعني. So she mobilized in the house with a cane.
Okay.
One cane. يعني مو 4 wheel walker a cane. أصاحب يدها اليمين وتمشي أمورها ما عليها الحدود.
The second thing, I have to assess the target on the echo, in the cath, and I need echo for her.
So targets are very reasonable, easy accessible. Very reasonable, easy accessible.
Easy accessible. Okay.
Echo with the normal ejection fraction is actually she had LVH and hypertension. Very thick, well functioning muscles. يعني ejection fraction more than 50%. ممكن there is evidence of hypokinesis in the anterior wall. Otherwise everything looks good يعني. عندها aortic sclerosis, mild aortic stenosis, but nothing significant otherwise within normal. عندها شوية MAP. Otherwise mild to trace MR. يعني typical 8 years old.
I will move forward for examination. I will examine her for the previous stroke, any defect. I will see the chest, and I will listen to the carotid brewery, heart chest examination, heart and respiratory, and I will assess the vein for varicosity and peripheral vascular disease.
Physical examination, all is unremarkable. There was evidence of Brewery and both carotid. You did a Doppler study, 50%, both sides, not more than that.
And the stroke, when was exactly?
She told you 10 years ago. She doesn't remember. She had weakness and it resolved.
Okay. Blood work, I will order baseline CBC, liver function test and renal function test, coagulation profile, thyroid function test, and urine analysis. And if I will go with the surgery, I will order, depend on hospital protocol, but in our hospital we order hepatitis and HIV in all surgical patients.
Okay.
And cardiac enzyme.
CBC, she has anemia, hemoglobin 90, otherwise unremarkable.
Hemoglobin 9.
9.
Okay.
As I told you, عندها evidence of chronic kidney disease, GFR of 60, but otherwise she's okay. Coagulation profile is within normal. She does not have hepatitis B or C. She does not have HIV. Your liver function test within normal, her abdomen is around 20 يعني ما عليك. Not that low يعني.
According to the hemoglobin, I will order occult blood in the stool just to make sure everything negative. And cardiac enzyme, I will order ECG, chest X-ray.
ECG showed best T-wave changes in pericardial leads, and that's about it. ما في حاجة ثانية. Maybe evidence of LVH. That's it.
Chest
X-ray is within normal. ما في حاجة unusual.
No calcification, nothing.
No, nothing obvious. يعني.
We already discussed the echo and cath. No need for viability if it's echo normal ejection fraction and there is no wall motion abnormality. So this patient, if the score and frailty, she is not frail, and it seems I need to calculate the score, but it seems it's low to intermediate, and
that's true. It's low to intermediate. No more, not more than intermediate.
Yeah.
Because otherwise she can walk around the house with a cane at least.
Yes. This patient there is clear indication for CABG due to the left main and complexity of the left main. There is no rule of BCI in this patient. So I will schedule her as elective. She is non-STEMI and she is out of chest pain now as elective. And I will
What's the timing of STEMI with CABG? Can you send them home?
Non-STEMI?
Yeah.
Yes, we can send him home, but not this patient. This patient came with critical, sorry, I said, I missed this. She came with a critical left main. She should done an urgent base. She will not leave the hospital before surgery.
Exactly, very important. Okay, so when would you do it?
I will do it within days, 2 to 3 days. But if I don't have any other cases more urgent than this, I will do it next morning if she finish all the workup.
So she's frail with low hemoglobin. Why wouldn't you do it tomorrow if she's stable? Why?
Yeah, next morning. That's tomorrow.
Why? Why wouldn't you do it? I would not do it myself. Next day.
No. If she finish all the workup, I will do it next morning.
Why will you not do it the next day? She's stable. ما فيها حاجة.
But
مو بس نزلوها الفلور بالشركة. نزلوها الفلور وحطوها على التلمتري بس.
But you said 99% left main.
No, 90%.
90%. Yeah, but we can do it within a few days.
Why would you wait longer?
But
why?
Why we wait longer?
Yeah, in this patient, yani, if you can wait, it's better.
To stop the blafix.
Exactly.
Yeah, to stop the blafix. Sorry.
يعني هي frail or lady.
Yes.
Not frail, يعني mildly frail, anemic. يعني you anticipate fragile tissues. So bleeding is horrendous مع الإنسانة هذه. Just horrendous. You want to take her in the best optimal condition.
Actually,
قررت تعمل كبد واحدة عمرها 80 يعني.
Yes. No, actually, because finishing all this workup, it will take around 4 to 5 days. And
بس أنت ما قلت يوقفون البلاد.
Yes.
الكارديولوجيست مكملين وما دروا عنك.
صحيح.
You have to specify. Meanwhile, how can you manage her يعني؟ إذا وقفت البلاد, what can you do?
You
مثلا blood thinners once. Blood thinner يعني to keep her blood from.
She will be on aspirin, and we can add for her heparin infusion.
Exactly. في حاجة protocol الهيبرين يكون lower dose. She doesn't need to be fully anticoagulated يعني. You can use the anti-tenias الجدد هذول إذا تبغى يعني بعضهم. ما أشوف which one is good. Okay. After 5 days, she looks great, no symptoms. Platelet function test was normal. We took her in the morning with the plan to do CABG 3. Hello? You notice while open her, her skin is really thin. She has not much fat, given her age. The bone is really osteoporotic and really fragile tissue. So you took your time dissecting your conduits.
Okay.
So you calculate it in usual fashion. عملت your CABG 3. Everything to you seems okay. You remove the cross clamp and start to prepare to come off bypass.
معلش دكتور صوتك يقطع شوي معلش.
Oh, sorry. واضح الحين؟ ليش يقطع؟ ما ادري. الو؟
اي معك.
اوكي سوري. انا جالس جنب الراوتر. اي عملت الكابج the start. You took her to the OR. You noticed that her skin is really thin, no fat, very osteoporotic sternum. You took your time to take her manually يعني. You took your time. حتى السيستم حقك يقول لك الفين يعني very fragile tissue. So you cannulated, you went through the surgery يعني. You took your time, عملت your cannulation, عملت your distal and everything to you looks okay.
Okay.
So now you're preparing to come off bypass. While mid-flow, يعني الحين أنت around 50% flow, يعني around 2 liter, 2.5 liter, everything looks good. Suddenly, the patient starts to have arrhythmias. Yeah. What do you think? What's the cause?
I will go back on full flow. There is multiple reasons. One of them, it's air in the coronary.
How do you manage that?
You open the vent and you milk the coronary, or you de-air with the needle on the top of the vein graft.
Okay, you did that. What else?
Electrolyte abnormality.
Normal. Everything is normal.
Hypothermia.
The patient's normal therapy, 36.5.
If there is anything wrong with my graft, that's ischemia. It will show an ST segment elevation in the monitor.
Okay, so your right graft visually looks okay. Your OM graft looks fine. You de-aired it. You barely see bubbles. Then you looked at your LED. There is evidence of hematoma in the pedicle. So what do you do at this time?
I will measure the flow with the flow meter. If it's excellent flow.
At the right side, there was a flow of 50 ml with a diastolic percentage filling of around 60-70% and a PI of 2. The right OM showed a good flow and the 70 ml, PI of 1.2. Diastolic filling percentage, diastolic flow percentage is more than 70. It looks great here. Lima to the LED, flow 15-ish. بالكثير. And PI is 6.
BI is 6.
Yes.
Yeah, there is resistance in the Lima flow. If there is significant hematoma, that's mean it's. I will try to put some babaverine on the outer surface. If the flow improve, if we have TE, I will ask to see the contractility. Sorry, patient still on bypass. So if I'm questioning the anastomosis and there is hematoma, I will redo the anastomosis. If I have good length with healthy length with Lima, I will do it with Lima. Otherwise, I will put vein graft on the LAD.
Okay, so you went back on. You took down your anastomosis. and start slicing open your LED. So you have to open it عشان تعرف صح ولا لا؟
Yes.
You opened, you notice that giving her tissues مع البريشر العالي وكذا she started to have one of your clips midway caused a tear in the intimal وعملت لك intimal flap out of your control. حطيت كليب وللاسف الشديد عمل لك فلاب من داخل. فالهيماتوما was extending up to the mid lima. What would you do?
She is 80. I don't want to waste time fixing the lima or take it as free graft. I will just put a vein graft.
Exactly. So, if you decided to redo the lima on 80 years old, لا تضيع وقتك. نادي الاسيستنت يطلع لك فين. انتهى الموضوع. This is what I want you to say. ما re-think. انت اول ما تشوف هيماتوما والفلو تعبان there is no point انك تطلع الميموري examine it تضيع وقت cross cramp. You already cross cramped her prior. هذه frail lady. If you decided to redo it, just redo it. اطلب بين وانتهى الموضوع. You get the picture?
Yes.
لانها ما راح تفرق معها بالبروجنوسيس وايز ان ذا لونج ران. اوكي. هي عمرها 80 يعني. اذا بعد العمليه عاشت 90 she's better than the population of Saudi Arabia. يعني الظاهر المين ايج بالفيميل في السعوديه 76. Okay?
Yes.
Okay. Any other questions? عندكم اسئله يا شباب؟ الو.
No, thank you.
معك.
Okay. Who wants to do the last case?
Osman.
Okay. Okay. So, Osman?
Hello.
Okay. So, كلموك الكارديولوجي. مريض محول من الحفر. جاء عندنا الباطن. He had anstomy 5 days ago. They managed to without cervix. He looks good. حولوه من الحفر to our center for a test. عملوا له CAT that showed just 3 vessel disease. Very diffuse 3 vessel disease يعني. Very calcified proximal RCA. Calcific, but reasonable PDA target. A very proximal calcified proximal LAD, but there is a good reasonable distal target beyond the diagonal. ونفس الشيء عنده very calcified circumflex بس في an OM disease يعني. وقالوا لك تعال شوف المريض.
Okay, we'll start with the history of the patient. He's at 65 years old. I will ask for any the duration. You said 5 days with non-STEMI.
حولوا وعملوا له كاف يعني. طلعت severe 3 vessel disease.
Yeah, and he's now stable and no chest pain.
No chest pain, nothing.
So just I will go through with the history of the patient, trying to find any comorbidities and risk factors with regard to diabetes, hypertension, atherosclerosis, peripheral vascular disease, and also history of any TIA or stroke.
He tells you, I've been diabetic for the past 40 years. For the past 5 years, I switched to insulin. I'm a heavy smoker. I still smoke. I tried multiple times to quit smoking. I couldn't. Nowadays I cut down to half a pack a day. يعني 10 cigarettes. I have hypertension. They give me a pill for it. And I'm not sure if I have high cholesterol, but they give me a pill for it too.
Okay, from the history, he looks like I have uncontrolled diabetes since he was switched to insulin. I might dig into that to see if he's really controlled or no. And his blood pressure, he's hypertensive also. And given he's a non-STEMI, I will proceed with workup for the patient with the labs. will send for.
Would you ask more on history? أنت سألت stroke. طبعا he told you. They told him he had a TIA a few years ago, but nothing happened. They just managed him medically.
A few years ago, how many years?
Yeah, يقول لك 4-5 سنين.
And there is no.
I had some weakness. رحت مستشفى الحفر. They managed me a few days in the hospital and they discharged me. They did nothing. يقول لك.
Okay. And he's not on any antiplatelet therapy.
He is on aspirin Plavix now.
Aspirin Plavix. And any residual deficit.
No.
Yeah, this one I will take it also in the workup. Maybe I will order CT scan for him just for a baseline for me.
You could do that.
And from the package also I will do the carotid Doppler, the echo, and CT scans, and also the labs for him for the CT, the renal function. And
Anything in history you want to ask for and roll out?
History to roll out.
Anything in past medical history you want to ask about?
I already asked about the most of the comorbidities that he will have.
You asked him about his past surgical history, and
He told you they did a procedure to his lower limbs.
so when you dig further in his history,
He has a history of intermittent claudication. He was seen by a vascular surgeon 5 years ago, and he had a FEMPOP, right FEMPOP.
femoral popliteal bypass.
Mhm.
عملوا له right popliteal bypass 10 years ago.
Okay, so he have a history of peripheral vascular disease.
Yes.
And also I might ask for angio for our CT angio for the lower limb.
Okay. So summarize your work again.
My workup will be the echo, the carotid Doppler, CT brain for baseline, and CT angio for the aorta and the lower limbs.
Okay. Okay. So you did labs. Let's start with labs. And X-rays and ECG to start with. X-ray, there was suspicion of calcium deposits and the aortic notch, very suspicious. Echocardiogram showed an ejection fraction around 50%. There is some evidence of septal and lateral wall hypokinesis in that left ventricle, otherwise all within normal. Some calcification around the aortic valve, but it's functioning normally. There is no evidence of stenosis or regurg. An ECG showed some T-wave inversions in the pericardial leads, otherwise nothing significant. What else? You did a CT, showed evidence of ascending aortic calcification, mainly on the inner surface of the ascending, extending to the lesser curvature of the arch, all the way down to his iliacs. His right common or right external iliac and common femoral is 100% occluded. There is 70% occlusion in his left common femoral. He has evidence of SMA occlusion, but his celiac and IMA are open. His left kidney is around 70% stenosis and the right is okay in a CT scan. What else I missed?
CT
واضح
brain.
صوتي ولا تقطع؟ واضح صوتي صح؟ Okay. The CT brain showed no significant ischemic changes. It's fine. Carotid showed bilateral 70% stenosis in his common carotids.
So currently, this patient have an indication for CABG, but giving the history of the patient, he needs to be carefully managed and to improve his current condition with regard to his atherosclerosis and peripheral vascular disease. And surgery can be done in an elective fashion. So I will consider sending him for a vascular surgeon to take his opinion about for the lower limb and for the atherosclerotic aorta.
So Jack, cardiologist, قال لك يا دكتور عثمان, he has really diffuse coronary artery disease. I wouldn't be comfortable discharging him, although he's stable. But I will not be happy to discharge him. Yani he has really, really bad coronary artery disease. So in contrast, he asked the vascular surgeon to come and see him. وعملوا له studies. كان واضح جدا إن في not good flow to the right lower limb. But the left limb is okay. يعني. It's not bad. And he told you currently he would not, vascular surgeon, he would not consider intervening on that. He doesn't want to intervene on it yet.
Okay.
And he thinks the heart is more important and he doesn't want to touch it now.
And the same for the carotids. He doesn't want to intervene.
No, he doesn't want. He said it's 70%. His last stroke, 5 years ago, he doesn't want to touch it.
Okay. So I think I can proceed with the CABG, but within few days, since patient on aspirin and Plavix. I would consider stopping these and put him on heparin.
Okay. So Plavix was stopped. He switched to heparin. He was seen by a diabetic specialist. They optimized his treatment. You found out his hemoglobin A1C was around 8ish. It's not that bad, yeah. It's okay. Otherwise, he's okay. Yeah. So when would you operate?
Since you have almost 5 days, so I think it's safe to take him at this after the few days of stopping the Plavix.
Okay, so 3 days after stopping Plavix, his vital function tested within normal, you decide to take him. What is your surgical plan?
Surgical plan, I will take him with through Midline Strenotomy, and for the cross clamping, I think I will try to have aortic ultrasound. I might consider off-pump coronary bypass grafting for this patient.
So on the CT, he had a lot of calcification. They look like mainly the inferior wall حق ascending, including the arch. So typically, okay, maybe you'll find a soft spot anteriorly, but if you put a cross clamp, you might crush the posterior calcium. So that's an area of a concern. عملت aortic ultrasound, you might find a small spot, soft spot, distal ascending, but you're not sure about cross clamping. And then when you scan the root, there was a lot of calcification in the sinuses up to the ST joint junction, and في calcium. It was obvious. Ultrasound, yeah.
I will consider the off-pump CABG.
So what conduit would you consider for him?
I might take all arterial Lima.
Exactly.
Skeletonized, or I take Lima with sequential grafts with veins.
So how are you going to sequentialize? He has a 3 vessel disease. Can you sequentialize it with the Rima?
With Rima, I was sequential vessels. I will sequential the 2 with Lima and 1 with the Rima.
So tell me your plan. How are you going to set up your grafts? Remember, you're doing a PDA, LED, and an OM. CABG 3. How are you going to set up your graft? كيف تعملها؟
grafts. I will do the LED, the Lima to LED distal, and then with a sequential graft to the. Then I will take the Rima and connect to the OM and BDA.
And your proximal rima, what are you going to attach?
To the LAD.
So that is called a Y graft. When would you do your Y anastomosis and why? Based on what you say, you took a lima, then you took a 3 rima, right?
Yes.
Okay, so when would you do the proximal anastomosis of the rima? When would you do it?
When or where?
When? And where? Both.
I'm not sure.
Okay, you could do that, but this strategy is viable. You could do it, but it makes your surgery quite complex. If you decided to do that, typically at a level of that sternal angle, where you typically perform your slit, you attach your proximal rima in a Y fashion before doing your distal. The reason for that, you want to make sure the lima outflow can fill up both adequately, your distal lima and distal rima. Doing a sequential OM or pump is quite challenging. I would not do that, صراحة. يعني أنت فكر فيها. You're gonna do an OM, a PDA, a distal rima, then you're gonna lift the heart, and you do a side-to-side anastomosis. It's not an end-to-side. In a sequential, you could do that. There is 2 issues. واحد, it's quite a long distance from the PDA to the OM, so you have to make sure إن ما في tension segment of the rima. And then doing a side-to-side anastomosis or pump and OM, it's quite challenging. I wouldn't do that. What other easier strategies to do?
Easier strategies.
Easier, يعني. حاجة سهلة مرة.
Not sure.
You could do a lima to the OM and a rima to the LED. You could do a vein to the PDA. When I told you there is a soft spot at the distal proximal aorta, you can safely apply a side clamp to do your proximal. Is that clear?
Yes.
Okay, so you conducted your plan. You did all your bypasses, everything went well. And then suddenly there is a dark bleeding after your anastomosis in the LED territory, the dark blood. What would you do? What do you think it is, and what you're gonna do?
I cannot hear you again.
أقول, you did your surgery, كامل, you did everything. بعدين, okay, you did your surgery, you lowered down the heart, but you found dark bleeding after the anastomosis close to the LED. How are you gonna deal with that?
Dark bleeding is at the site of the LED?
After, around your anastomosis.
Around it. Mostly from the venous system.
Okay.
So if it is small, I might cauterize it. If it's big, maybe I'll put a stitch on it.
Okay. Cautery is not advisable when you cauterize close to your pruning stitches, you might melt them. So you can either use stitches if you can identify the vein, or you can apply a topical hemostatic agent. Most of the venous bleed will start with protomy and a topical hemostatic agent. Is that clear?
Yes.
Let's say in a different scenario, the LAD was intramuscular, and you had to dig through the muscle to do your anastomosis. What other things you might consider causing the dark blood?
Intramuscular. The same. I will apply some pressure maybe on the venous to stop it. And
It did not work. Keep flooding on you.
and topical hemostatic the same.
Did not work. حطيت قعدت نص ساعة. Nothing is working.
If I closed on the LAD, maybe it will jeopardize the flow to the LAD.
Yes. You tried everything. حطيت بروتامين، حطيت بريشر في يدك، حطيت تاكوسيل، حطيت تسيل، حطيت كل حاجة عندك موجودة بالشلف حطيتها. Did not stop. Keep welling up, dark blood. Again, I'll emphasize that LAD was intramuscular.
Maybe I anastomosed intramuscular to the veins.
Commonly, no. That was not the case. If that's the case, you'll see ST changes or fibrillation. The heart is injecting ولا عندك أي مشاكل يعني. وعملت ميديستال وعندك excellent flow. The anastomosis are excellent. عندك flow of 100 with a PI of 1 يا شيخ. أحلى flow من ريما تدالي أحلى flow. No issues, zero. Anybody knows from you guys?
I will make sure that I did not perforate the
Yeah, most likely.
ventricle.
Yes. RV.
What ventricle commonly?
RV.
How can you fix that?
Okay.
You take deep stitch under the lima with the pledget, but make sure you will not occlude the lima. Deep stitch on both sides of the LAD under the LAD as a U stitch.
Exactly. What kind of stitch would you use?
What?
What kind of stitch?
Pledgeted stitch.
Prolene.
Prolene
Like what?
4O.
I would use bigger. تبغى needle تروح around it. For all the smaller needle, I wouldn't go less than 3O. And then when you apply your pledget both sides, you just have to snug it. Don't over tighten it. Okay?
Okay.
Any other questions? أسئلة شباب? Questions?
Similar case, if I'm facing, let's say in the exam, this case, but I have to go, or let's say I need to do off pump.
Yes.
So to be honest with you, the off pump, I never did the sequential. So, but I think the LAD, myself, I did LAD on pump. I know the principle. I was assisting many cases off pump. So if I will call for help. But if then in the exam if I say, okay, I will do off pump, just lima to LAD, and the other I will call my colleague, the cardiologist in the OR, to see if he can do stenting for the other vessels.
So
because I'm not that expert.
Yeah. So that's true. احنا في البطين we do quite a number of cases of pump. فعثمان is quite, he's seen them a lot. If you can describe off pump accurately to your examiner, I think that's an okay answer. Me personally, in my training, I did not do a lot of off pump. The only off pump I did, especially during my minimum invasive fellowship, هو ليما الأبدي فقط. It's easy, accessible, and doable. So my approach to this patient will be exactly like you, Haitham. I'll do a Lehman LED in a hybrid room and see if we can set the rest of the vessels.
Okay.
So that's a valid option. I would do that.
طيب دكتور عبد الله لو سمحت technical problem بس في الاختبار لو الاكزامينر he chose
اولا before you ask me you have to understand انا ما اعرف السيت اب حق الاكزام. I don't know how many minutes, and I don't know the expectation, unfortunately.
لا اقصد
I'll answer in the exam based على my experience في Royal College.
that will be fair.
يعني اللي اجاوب لكم عليه خذوه يعني with a question mark. يعني انا ما اعرف صراحه. I don't really understand the setup حق الرويال كولج exam او السعودي بورد exam هنا so far يعني.
No, my question in general,
Okay.
if the examiner choose the strategy for me for this patient, the examiner يعني choose the strategy of total arterial revascularization, for example, and I want to do, or I prefer to do hybrid procedure. Shall I mention this or just go with him to the direction he want me to go?
What would I do? I'll just let's say this patient نعتبر نفس السيناريو بس عمره 50 سنة. Let's say. والاكزامينر اللي قدامك an off pump expert ومصر تيجي تقدر تقول له giving my training expertise that will not be my preferred option. I will ask a senior colleague to help me. بيقول لك اوكي انت في الاخير you have to prove safety صح ولا لا؟
صح.
إذا هو مصر إنك تروح total arterial, he probably wants to see your technique. Do you understand how to do it? He doesn't expect you to be able to do it. بس يكون الهدف من السؤال يكون مثلا السؤال محطوط can this candidate do a total arterial and how his approach in organizing الconduits. هذا يكون هدف السؤال. فهمت قصدي؟ يقول هدف السؤال انه كيف حسين راح عنده تو اي ام اي كيف راح يوزعهم يعني
اوكي
without hurting the patient. فهمت قصدي؟ يكون هذا الهدف من السؤال يعني كيف تسوي organization حقك and why. So I don't يعني if I was in the Canadian board بقول زي كذا بقول I'm not experienced. I'll ask for a senior colleague. The least I can do is Lima NAD and stand the rest. إذا أصر على total arterial بعدين بقول له إذا ما قدر do it I'll consult a senior colleague but this is my strategy. يكون الهدف من السؤال إيش؟ يبغون يشوفون أنت كيف راح توزع الارتيريال جرافت خاصة إذا قررت تسوي بينا الراديال.
اوكي.
احنا نعرف الجايد لاينز هل تحط راديال على الرايت هو 70% ولا ممكن هذا يكون هدف من السؤال. هل تحط الراديال على الليفت سيركمفلكس ولا لا؟ وين بتحط الليمه؟ وين بتحط الليمه؟ فهمت قصدي؟ يكون هذا هدف السؤال كيف توزع جرافاتك. اذا اصر this is what I think. والله اعلم.
الله يعطيك العافيه.
Any other questions? Okay. يعطيكم العافيه شباب.
العافيه دكتور.
حاجه شباب؟
الله يعطيك العافيه.